Hello, my name is Dr. Ralph Abraham, and I am a consultant diabetologist working at the London Diabetes Centre. We have all read of our Prime Minister's recent interest in obesity and losing weight himself after his terrible COVID illness. This may be one of the nice things that comes out of the COVID pandemic, the realization that pretending that obesity doesn't exist and should not be characterized as a disease is not tenable anymore. So we will have more interest and money thrown at this massive problem, but much more of it will be directed at methods that have a track record in failure. Encouraging people to change their lifestyle with dieting, education on what foods to eat, more exercise, and taxing sugar-containing foods, there will undoubtedly be some success. But I doubt that it is going to be sustained success. People who are strongly motivated to lose weight will always succeed with ongoing support and education. But it takes time, it takes effort, and quite often it takes money as well. And not everybody who has a job and who has family responsibilities can muster the determination and the organizational skills to make this happen. Over a long period of time, let's say just 5 years, this continued motivation rarely persists. And the costs of dietitians and special diets, ongoing support and gym memberships all mount, and people rapidly lose interest and regain the weight they had lost. I believe that where an assessment is made that long-term weight loss will not respond to lifestyle changes alone, then we must consider surgical or medication add-ons. People do worry about their weight, even those not seriously overweight, and they are the ones that will most respond to lifestyle measures alone. But we forget that losing the top 5% of weight is responsible for the greatest health benefits. So any weight loss, even 2 or 3 kilograms, is a bonus. And people they spend on gyms, on diets, on trainers, on dietitians, and they stress themselves to depression about it. There has been a healthy weight loss industry for years. Why? Because people have to keep coming back. And every January, straight after Christmas, all the advertising on television and newspapers once again exhorts people to repeat this futile cycle. Politicians mull over a sugar tax while giving GPs millions of taxpayers' money to spend on weight loss programs and gym memberships. Yet the problems inexorably get worse year by year. Not so in many patients in my practice where maintained weight loss is frequently seen. Why the difference? Are the people different and more motivated? Is the advice different? In our Smart Weight program at London Medical, we have made sure that 5 important ingredients are included to maximize a good outcome for our patients. They include having an enthusiastic healthcare team for long-term advice and support. What this means is that you don't just give someone a diet sheet and say goodbye, do it yourself. They also include having a buddy at home, and this is so important and sometimes forgotten. They include having a realization and commitment that this is for the long term. This is not a short-term dietary fix. This is a lifestyle long-term change. It means that the patient needs to sensibly participate in the menu planning. And of course, I do believe patients need help with medication when possible. Getting everything pointing in the right direction in every patient is not always possible. Are there different approaches? Yes, there are, and it is something that I find interesting. To some extent, failure in weight loss is good for business. The customer keeps coming back. I have worked with overweight people now for more than 30 years. The statistics do not make for good reading. Some of the best weight loss clinics only succeed in achieving maintained weight loss over a year of less than 5% of the initial body weight. And that figure is much lower after 5 years. So we can all go to commercial companies like Weight Watchers or eat dehydrated foods or purchase proprietary milkshakes or go to spas to be fed miniature teaspoonfuls of soup all day, and we can all lose weight. But we cannot do it for a long period of time. In the middle of a life that contains work, traveling, children, holidays, and worries. So what has changed? And is there some hope for all of us sitting in front of our computer screens, assaulted by prepared, enticing menus without control of what we eat, sweating while trainers and gyms exhort us to do more, and facing the inevitable onslaught of resulting increased cancer, diabetes, back problems, sleep apnea, COVID-19, cirrhosis? Because make no mistake, that is what an increasing waistline and obesity comes down to in terms of health. And at increasing cost to our NHS, that can spend large sums of money on cancer and diabetes, but not on obesity solutions. That actually is the root cause generating more of these conditions. What is different now comes from the world of diabetes, a world in which I practice. For more than 12 years now, I have used a group of drugs for my patients with diabetes that have turned out in time to be wonder drugs for diabetes. When liraglutide, whose brand name is Victoza, and its predecessor, exenatide, whose brand name is Byetta, first came out many years ago, they were relatively expensive compared to other diabetes drugs, little known, and had side effects that required management. They also were injectable therapies. At the London Diabetes Centre, we quickly realized that patients who could be encouraged to inject themselves daily and learn how to bypass the side effects were doing well, not just from their diabetes, but also because they found it easier to manage their weight. Weight loss encouraged by advice and sound, sensible, healthy eating habits was maintained. And the yo-yo weight cycling that had been in the norm in the past for these patients had disappeared. Patients did not want to come off their Victoza, which was at that time a recommendation from their GP. If the patient lost weight, the Victoza should be stopped. Wrong. If the patient had lost weight, the Victoza should be maintained so that the weight loss was maintained, a lesson that we took many years to learn. Now, a decade later, we have learned that this therapy, by helping patients to lose weight, has also reduced their risk of cancer, helped their heart and their kidneys, relieved their back pains, and delayed hip and knee operations. That was serendipity. We didn't know that at the time. But then, now when we know that this is a likely health outcome, it does not seem to change prescribing habits. And only those on the inside, and those perhaps who seek our advice here in this clinic, are seeking out clinics and doctors who understand this and who can help their patients' total health. Since pioneer drugs such as Byetta and Victoza, we have better and stronger drugs of this class, which are known as the GLP-1 receptor agonists. These drugs can now be given weekly by injection, and most recently, just this week, there is an oral version that has now been launched. The fan base for this group of drugs is widening. It is not just because these drugs are the strongest glucose-lowering agents around, but because of their associated weight loss. And this weight loss is worth at least one other diabetes medication. So it does save money in the long run. The drugs lead to substantial maintained weight loss, obviously with encouragement on lifestyle and dietary changes, and patients see this as a priceless aid in their search for a more healthy outlook. The improvements in well-being, alertness, and increased self-esteem in somebody who has lost 5 or 7 kilograms in weight, that's up to a stone, and has failed to respond to dietary encouragement for many years, has to be seen to be believed. The NHS manages to prescribe these drugs to only about 20% of people with diabetes. And some of the more modern and powerful weekly drugs are prescribed even less frequently. There is much, much higher rates of prescription in Denmark, Switzerland, Ireland, the Netherlands, Sweden, Norway, Finland, Canada. Why is this? Why is it that after 2 years after the launch of the most powerful weekly agent, we're still unaware of its existence? Clearly, immediate costs of the medication play a huge role for the NHS, which is burdened by the costs of diabetes. And we already have increased the spending on diabetes medication substantially. After COVID and the way the economy's been hit, the NHS is going to struggle to be able to pay all these bills. But there are other drugs in diabetes that also have useful heart and kidney benefits, and that also lead to a smaller degree of weight loss. This group of oral drugs is called the SGLT2 inhibitors and include brands that patients would recognize called Invokana, Jardiance, Forxiga, Stilagro. Taken together with the GLP-1 agonists weekly when indicated, the weight loss achieved is striking. Now we have the world's first oral GLP-1 agonist, Rybelsus, with all the glucose-lowering and weight-losing properties of its sister weekly injectable GLP-1 agonist called Ozempic. So the future for those with diabetes and central obesity, with all the increased known hazards for cardiovascular events, kidney disease, eye disease, and nerve damage, have never been so good. Doctors and people with diabetes should collude to promote greater use and confirm the increased total health benefits of the accompanying weight loss. Thank you. This is Dr. Ralph Abraham from the London Diabetes and Lipid Centre.